Hey guys, it's Gianna, MidwiFay. I am so happy to be back starting to film more videos for you guys. If you've been around with me for a little bit, I've taken a few months off as I had my third baby in February, and so she's about 7 months old now. I'm starting to get the groove with the 3 kids, so I am just so excited to come back and start filming more YouTube videos for you guys. I'm super passionate about putting out videos that are educational for you and that deal with things that we are dealing with right now in common OB practice. And what I keep seeing a lot of right now are inductions. So I thought, why not do a video on what an induction is, what are the reasons we recommend for people to be induced, what are the methods of induction, and kind of get all into that. And then I also am starting a whole induction series to go over common medical indications for inductions and other reasons that people are induced, to kind of hear both sides of the story. So let's get into it. Always, I want to encourage you, please like this video, subscribe to the channel. It really helps me know which videos you guys like and what other content you want. So please go ahead and like and subscribe if you haven't already. Let's first start off by defining a labor induction. What is it? A labor induction is when we, medical practitioners, start your labor before your body has, okay? So that is using medications or other tools to get your body, your cervix to start dilating, your body to start contracting, to start labor. The idea of a labor induction is that we want to start labor and have the baby be born now, either for some risk to mom or risk to baby that we think would increase if the pregnancy progressed past that point. Some common medical reasons for labor induction include hypertensive disorders of pregnancy, so that would be gestational hypertension or preeclampsia, or diabetes in pregnancy, either pre-existing diabetes or gestational diabetes, specifically diabetes that is requiring medication or insulin to manage blood sugars. Another common reason for induction medically is late term or post-term, more rarely pregnancy. So there are a few reasons why your OB or midwife might recommend that you be induced towards at some point in your pregnancy. Depending on the reason for your induction, there are different gestational ages at which we recommend starting it. So that all depends on policies and procedures, research done by Maternal Fetal Medicine Society, ACOG, other organizations that kind of have done large-scale studies that say, okay, with this diagnosis, at this point is when we recommend induction. So it's not universal to everyone. It depends on the reason for your induction. I will say, I did a video, I'll post it here, about the ARRIVE trial and kind of this idea of induction after 39 weeks of pregnancy without any true medical diagnosis. I'll definitely get more into that later on in the induction series, but in general, before 39 weeks of pregnancy, you have to have a medical indication for your pregnancy, for your labor to be induced. After that, there's a little more wiggle room on if you wanted an elective induction or if your doctor was recommending an induction after 39 weeks. So how do we do a labor induction? Usually, we do an exam to see where your body is starting. We use something called the Bishop score to tell us what your cervix is doing. Is it soft? Is it thin? Is it dilating? Is it open at all? Where's the baby in the pelvis? So we use this Bishop score to determine how we are going to proceed with your labor induction. The beginning of most labor inductions involve some element of cervical ripening. Cervical ripening is that process where we're trying to get this Bishop score into that 4 or 5 range. Okay, so we want to get the cervix soft, move it forward, thin it out, and have it to start dilating. Common tools we use for cervical ripening in this early phase of induction are dinopristone. It's a prostaglandin, usually in the form of a medication called Cervidil, which is a vaginal insert. There's also vaginal gels that have dinopristone. Another common medication is misoprostol. It is a pill that can be used orally or vaginally placed as well. All of these are prostaglandins meant to kind of get that cervix ripe and ready for later phases of labor. Another common tool we use, non-pharmacologic, is something called a cervical ripening balloon. You may have heard it called a Foley bulb, cervical balloon, bulb, whatever. People call it a lot of different things. And what it is a plastic tube similar to a urinary catheter, honestly, that we place through your cervix and we inflate it with saline. So what that does is it mechanically, physically causes the cervix to open and dilate. That physical opening, obviously, is opening your cervix and thinning it. It also is causing your body to release its own hormone, its own prostaglandins at your cervix. So all of that stuff is really that first part of early labor, cervical ripening. This is mimicking what, if someone wasn't being induced, what the body is doing on its own in the days, perhaps weeks leading up to spontaneous labor, getting that cervix ripe, ready, soft for the active labor phase. This part, honestly, is the most unpredictable part in terms of timing for a labor induction, especially for a first-time person giving birth. This part can last 12, even 24 hours potentially to get the cervix ripe and ready for active labor. This early ripening part, sometimes, depending on your hospital or your provider, sometimes this is done in an outpatient setting. So you might get a dose of a medication or a cervical ripening balloon placed in your doctor's office in the antenatal testing unit. They monitor you and baby for a little bit and send you home and tell you to come back at a certain time. So this is happening, I think, more and more in busy practice. So this part might take place in an outpatient setting versus just in the hospital, or you might be in the hospital the entire time for your cervical ripening. After the cervical ripening process, we examine you, check your cervix, see if it is soft, thin, etc. Hopefully you have a more favorable Bishop score, as we talked about in the beginning. Now we move on to the more active parts of labor induction. This involves IV Pitocin. Pitocin is the synthetic form of oxytocin that we have available as a medication in the hospital. We titrate it, that means we increase it according to how often you are having contractions, how you're doing, how your baby's doing, how you're tolerating, kind of getting into what we call an adequate labor pattern, which generally is contractions somewhere in the every 2 to 4 minute range that are causing your cervix to dilate. During the active part of labor induction is also when we might offer to break your bag of water. This is called artificial rupture of membrane, or AROM. It's done doing a vaginal exam and taking a tool usually called an amni hook to poke a hole in that bag of water, and it releases the fluid. That continues to signal to your body to make hormones to keep labor progressing.
After your water breaks, either spontaneously or because we break it, that is usually when the intensity gets stronger. So if you were planning to use an epidural or something else for pain management, likely you will be wanting that soon after your water breaks.
I say that to say labor inductions generally take longer than spontaneous labor. So anyone facing a labor induction should be prepared for the fact that if you're scheduled to come in at night to start your labor induction, can't tell you how many patients I see that come in, they're so excited. They get here at 9, they're like, great, and so baby will be here in the morning. And it's like, more than likely not. Your cervix is closed, this is your first baby. We've got a lot of work to do before we're even getting you into active labor, let alone getting you your baby, right? So I think it's just important to understand that a labor induction takes a long time. And honestly, as long as you and baby are overall well, tolerating things well, the more time we give your body to ripen and get that cervical ripening done, the better your chance of having a vaginal delivery. So if we can allow all of that cervical ripening to take place prior to, starting Pitocin, breaking your water, things like that, that is in your benefit for having a vaginal birth. So with that being said, here are some general recommendations I have for induction planning. One, if you know an induction is likely in your future because of a medical diagnosis you have, a pregnancy diagnosis you have, start to ask questions, talk to your provider, ask about what medications are available to you in the hospital setting. Some hospitals have multiple different variations of prostaglandins. Some just have one, and so you can know what is the timeline looking at for you at your hospital. Ask about balloons. Do they use balloons? Again, are they doing anything outpatient? Is it all inpatient? So instead of just kind of waiting for your doctor to talk to you about it, if you have hypertensive disorder of pregnancy or diabetes or something where you know that an induction is likely in your future, I encourage you to ask these questions early on in your third trimester so that you, your partner, your support people can start to be prepared for what an induction looks like for you with your provider at your facility. Another question I encourage you to ask is regarding the hospital's policy regarding things like eating and drinking in labor. Most hospitals, once you're in active labor, want you to only have clear liquids. So up until what point in your labor induction process do they not want you to eat anymore? That's important to know. Your hospital's availability of pain control meds and options, and at what point your doctor would or would not want you to be getting something for pain. Hospital policies on monitoring in labor in the early phase of labor induction versus the later phases. Are you continuously monitored the whole time, or do you get a break? Are you allowed to be on the Monica monitors or monitors that allow you to get up and move around? So these are all important questions to ask about your labor and delivery facility in general, but especially if you're facing an induction, because likely you're going to be there for longer than you would be for a spontaneous labor. So I would recommend asking those questions. And lastly, but definitely not least in my opinion, as I'm always going to encourage you to use your brain. Okay, I did a whole video on the BRAIN acronym, which is basically making sure to ask your provider benefits, risks, alternative. Listen to your intuition, okay? Make your decision based on these things. What if we did nothing, right? That's the BRAIN acronym. I think more times than not, people just listen to their doctor, listen to their provider, and say, this is what's recommended, so I'm going to move forward. Or maybe you're super tired and super pregnant and done being pregnant, and I get that, but you haven't gone through the BRAIN acronym to know what, if starting a labor induction, what could happen down the road.
Okay, that was a pretty basic overview of labor inductions, why we do them, how we do them, how long they can take. I just really hope that this information helped shed some light if an induction is in your future or if you're thinking about having an induction. I'm really excited to do this series on common reasons people are induced and to go over some medical indications and some other ones that I see happen really commonly. All right, please like and share this, subscribe. I will see you guys next time. Bye-bye.